where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Glad to be with you. Checking us out for the first time? Make sure you hit that like and subscribe button. It helps our algorithm and gets it out to more people. So we got a great show for you today. And joining me is my co-host, Lori Atkinson. Lori, welcome to the show.
Good morning, everyone.
Yeah. So I did put a teaser into the comments, if you looked at it, that there's a big announcement. Well, here's the big announcement. Hey, we have hit that mark, that big old milestone, over 3 million views of the UroNurse family programming. So I was kind of shocked that it started to really take off, but I've got to think having great co-stars and having great appearances from all the experts and you guys tuning in. So it's really for you guys. So, well, today's episode is going to be kind of a fun one. I started to think about things that we haven't necessarily talked about or be a good thing to talk about. And I know I go back far enough, and I think Lori probably goes back far enough with PSA. You know, when PSA came around, anybody with a PSA of 4.0 got biopsy. Yeah, absolutely. It was almost a reflex, you know, like a knee jerk. You tap the knee and it jumps up, you know. 4.0, you're getting in that chair. But that's changed. It's not that way anymore. Probably thankfully, especially now that I've reached the PSA age. So, well, I'm past the start of the PSA age, but deep into it. You know, that reflex of jumping in for a biopsy with a 4.0, we know was finding a lot of cancers that we call now renamed them to indolent cancers, meaning like non-cancer. They don't tend to have any effect on your life. So I thought, let's do a program. So today we go beyond the PSA. For decades, the prostate-specific antigen test has been the first warning light for prostate cancer. It improves detection and reduces metastatic risk, yet it remains highly sensitive but lacks specificity. In the next 15 minutes, we're going to walk slide by slide, get that, slide by slide, through the modern evidence-based pathway that replaces the old elevated PSA equals immediate blind biopsy reflex. And I'm part of that generation. PSA 4.0, you're probably going to be on the biopsy table. Now, shared decision making, secondary biomarkers, and multi-parametric MRI with targeted fusion biopsy have taken over. Now, let's begin. So the PSA, as I said, is a warning, not a diagnosis. While screening improves detection and reduces metastatic risk, it is highly sensitive but lacks specificity. On the low end, 15% of men with a PSA under 4 still have biopsy detectable cancer. On the high end, more than 67% of men with PSA over 10 have cancer. The noise is constant. Infection, inflammation, trauma, BPH, they all frequently elevate that number. A blunt 4.0 threshold captures way too many false positives and pushes men into the biopsy trap. So let's talk about the human cost of doing these blind biopsies. You know, 4.0 and boom, you're off for a biopsy. 1 million plus prostate biopsies are performed every year in the United States. Currently, only about 20 to 30% yield a cancer diagnosis. That's a lot of people getting a biopsy for nothing. Now, roughly 1/3 of the men who go through this experience things like transient pain, fever, bleeding, trouble urinating, and 1 to 3% actually face serious infections requiring hospitalizations. So these are not benign procedures. And the overdiagnosis rate remains high, especially for what we call indolent Gleason 6 grade group 1 disease. So the traditional pathway maximizes intervention while minimizing actionable clinical yield. Let that sink in. So step 1, verify the signal.
I don't know why we didn't think about this earlier. Repeat it and then reflect. People don't die quickly of prostate cancer anyway. The AUA guideline statement 3 clearly says clinicians should repeat the PSA prior to any secondary biomarker, imaging, or biopsy for a newly elevated result. Transient spikes from prostatitis, recent ejaculation, mild trauma, maybe bicycle riding are all common. The first clinical action is non-action. Allow time for inflammation to resolve before triggering that diagnostic cascade. The preference-sensitive decision. The AUA Guidelines Statement 1 mandates shared decision-making using validated decision aids before proceeding. On one side, the threat of metastatic progression and mortality. On the other, the reality of overtreatment, urinary incontinence, and erectile dysfunction. So what's our key takeaway? Discuss active surveillance versus radical treatment before a biopsy is ever scheduled. Patients have a word in this. Now, step 2, what's our biological risk stratification? We move beyond total PSA to identify molecular signatures. The goal of secondary biomarkers is to differentiate potentially lethal aggressive tumors, clinically significant prostate cancer, grade group 2 and higher, from clinically insignificant localized tumors or benign conditions. So here's our comparison matrix, the biomarker landscape that's out there. PHI, blood, combines total, free, pro-PSA. It's FDA approved, outperforms standard PSA for clinically significant disease. Select MDX. Urine sample measures HOXC6 and DLX1. Messenger RNA plus clinical factors. High negative predictive value to rule out aggressive cancer. 4K scores. Blood, 4 kallikreins, thus the 4K, plus clinical data generate a percentage risk for Gleason 7 or higher. Remember, we don't want to detect those Gleason 6s. Apini and MyCheck, blood algorithm-based probability scores. Now, here's a note. Commercial coverage does vary. Some of these panels may still be classified as investigational, but biomarkers should be your next step. The power of the negative predictive value. A high negative predictive value, or NPV, is the clinician's ultimate tool for de-escalation. Urine-based assays such as SelectDMX offer up to 95% NPV for ruling out grade group 2 or higher disease. The result? Between 34 and 43% of initial biopsies can be safely avoided while still missing a statistically negligible number of high-grade cancers. Now, the imaging revolution is the next thing we're going to talk about. Multiparametric MRI. The paradigm shift from blind anatomical sampling to visual physiological targeting. AUA Guideline Statement 13 recommends doing a multiparametric MRI prior to initial biopsy to increase the detection of, again, grade group 2 plus disease. MPMRI combines morphological assessment, T1 and T2 weighted imaging, with physiological mapping using diffusion weighted and dynamic contrast enhanced sequences. So what's that all mean? Well, we're going to get a score called the PIRAD, which is a way of risk stratification. Scores 4 and 5, clinically significant cancer is highly likely. Score 3, equivocal risk. Scores 1 and 2, clinically significant cancer is highly unlikely. Clinical action, any score 3, 4, or 5 designates an abnormal MRI requiring targeted biopsy. Key benefit, it standardizes communication and reduces inter-observer variability. Remember, delay MRI at least 6 weeks after any prior biopsy to avoid hemorrhage artifact. Now, why a multiparametric MRI before biopsy makes sense is all found in the Precision trial. Trajectory 1, harm reduction. 28% of fewer men needed any biopsy at all. That's always good. Being a man, I'm all for it. 13% fewer men diagnosed with clinically insignificant cancer, 9% versus 22%. Trajectory 2, yield increase. Significantly more men correctly diagnosed with clinically significant prostate cancer, 38% versus 26%. Multiparametric MRI simultaneously finds more of the dangerous cancer while ignoring more of the harmless cancer. That's a good thing, folks. All right, so what about the targeted fusion biopsy? That's what follows if you have an elevated PIRAD score. The AUA guideline, statement 15, we always use evidence-based here, for a biopsy-naive patient with a suspicious MRI lesion, clinicians should perform targeted biopsies. Now, software co-registers the multiparametric MRI images with real-time transrectal ultrasound. The clinician then navigates the needle directly into the PIRAD 3 to 5 lesion. Many still add a systematic template biopsy to ensure no peripheral disease is missed. So you're going to target it, and then they're going to do the standard 6, on each side, so 12 more samples. So now, here's the dilemma. We got a street here. We've got our biomarkers on one side, our MRI on the other, and we can have abnormal on either side. So let's take a look at it. Let's look at the path A. We have a low clinical risk found with our testing and plus a negative MRI, making it safe to defer a biopsy. Again, recommending returning to shared decision making and probably PSA and biomarker tracking. See what happens. If they change, that could change our minds. The other path is this way, B. Elevated clinical risk, meaning you've got negative MRI, but a high PSA density, strong family history, or concerning biomarker scores. According to AAUA Guideline Statement 16, it dictates proceeding with a systematic biopsy because a substantial number of cancers, including clinically significant ones, can remain MRI invisible. So it's not clear-cut, but it's getting better. Okay, so let's talk about what we're going to do here. Let's go to number 1. You got an elevated PSA greater than 4. What are you going to do? Repeat the test, talk to the patient, share decision making. Now, let's say we go number 2. We do secondary biomarkers. Confirmed elevation, low risk or high NPV monitor. Again, now we go over here to 3 with a high biomarker risks. We go on to do our multiparametric MRI with PIRADs, either negative, 1 and 2, or 3, 4, and 5. So if suspicious lesion, we go on to targeted fusion biopsy. It's all a step-by-step system that the AUA guidelines designed to eliminate reflexive blind biopsy. Makes sense. So 1, PSA elevated. Used to be right to the biopsy table. Now we do some marker tests. Marker tests come back negative, we watch it. Marker tests come back positive, we do a MRI. MRI comes back negative, maybe we watch it depending what some of those markers show. Or, most likely, we talk to the patient, see what we're going to do. But it comes back positive, 3, 4, 5. Now we got something to hit, target it with a fusion biopsy. Bang. That's the new system. So, big news is protect the patient. That's always our goal. It doesn't do us any good to put somebody in the emergency room with sepsis going after what was probably either a negative biopsy or a Gleason 6 biopsy that you really don't need to be treating. So the era of reflexive biopsy, from elevated PSA to blind biopsy, that's over, folks. Glad to have it done with. By methodologically integrating shared decision-making, secondary biomarkers, and multiparametric MRI, we maximize detection of lethal cancers while sparing men the profound harm of unnecessary interventions. So, always utilize the precision triage pathway to reduce overdiagnosis and overtreatment of indolent disease today.
Well, there you have it. That's my little talk on PSA and where you go. Lori, how does that match with what your group's doing?
It's pretty close. What we do is, of course, we get the patient with the elevated, just the PSA level. In most cases, we'll send them for a PHI test. And then based on that, we'll send them for an MRI. And based on the PIRAD score for the MRI is whether or not they'll do biopsy. So it's pretty spot on.
Yeah. And then they're doing the fusion biopsy, I would assume.
Correct. Yep.
Correct. Yeah. So that's pretty much where we're at. Now I moved out to Indiana, and one of the things I've been trying to do since I moved out here is move all my healthcare out to Indiana. I hate to drive into the city anymore. It's just a pain. I was from Chicago area, so even my own practice. So I did find a urologist out here. I just kind of make the whole step transition smooth. And I brought this point up to him because I was going to be talking about it this weekend. And he said, actually, my preference is, and it made a lot of sense. So his argument was, elevated PSA, free and total PSA, is that still abnormal or not? Then he likes to go to a measurement of the prostate against the PSA, or a PSA density. He said that the studies are showing PSA density is probably a better marker than the biomarkers. Now, he was referring to like the 4K, so he didn't specify all of them. He said, but that's his routine. He said, I would follow that pathway. And then if that's abnormal, you go on to MRI and treat accordingly. So I think that was kind of an interesting take on it. And his big thing, he said, I said, so what's your rationale for that? He says, biomarkers are expensive. He says, bottom line.
Yeah.
He says, and he says, it's coming out of all of our pocketbook because we pay for your Medicare. So he had a good point, but I think it made a lot of sense. So that density was something I didn't mention, and I probably should have put it into my talk. Anyway, do you guys do density as part of your workup or not?
No.
Yeah, usually the density is going to come out of a MRI. They'll do the MRI, then you can see if that's abnormal or not. But usually your trigger is going to be that PIRAD score once you've got the MRI. So
yeah, the interesting thing that we do now, we just actually started it probably last week, is the patients that are coming in for active surveillance. Instead of just following a PSA, we're now doing the PHI every time.
Yeah. So there's definitely some good evidence for biomarker following.
Sure.
I do have a couple questions that came in I'm going to bring up here. You can chime in on them too. Do they change the needle when getting a suspicious sample before going to the peripheral area sample? I think the better question is, do they change the needle between each sample? So what's your, I'll start off. We don't. It's the same needle.
I've never seen that either. Yeah.
It's the standard of care. It's what's been done. And he had a follow-up question. Fernando asked, if not possible, is there a chance to spread cancer to other areas of the prostate? And I am aware of studies that have been done that have not demonstrated any spread from doing these type of samplings. However, when they look back at some of the breast biopsies, which I think have been going on, or I know that have been going on much longer than prostate biopsies, that there was some question brought up in that. But I think at this point, there's never been good evidence that it's going to cause any issues.
Yeah.
So I don't see any other questions. So I think we kind of wrapped it up that, PSA shouldn't be a reflex anymore. We all started that way, but, I think you have patients. I know I had patients that ended up with going through the whole routine, getting a biopsy, finding out they have, 3+3 Gleason score or 6. And early on, that thankfully changed probably within the last decade, but we started doing this observation rather than treatment. But a lot of them were going on to radical prostatectomy, radiation, and, other treatments. And as nurses, we see the side effects, right? Incontinence. Patients are really upset with that, erectile dysfunction, which can be treated, but still it's there.
Yeah, it's gone a long way. Like you said, Vic, we biopsied so many people when 20 years ago or whatever, everybody got biopsies, and a lot of them came back negative, right? You'd get the random one. And now when you're doing it and you're getting these other studies, most biopsies that we've done have come back positive. Most of them, probably, I don't
Yeah.
even know a percentage, but there's very rare now that you get negatives with all this testing. So all that
Yeah.
unnecessary biopsies we did, it's fantastic now. Now, everything is not 100%. I have seen MRIs with PIRAD 5s come back negative.
Sure.
I've seen the 3s come back positive. But for the most part, it's really, they're great tools.
Yeah. Yeah. No, that's a good point. I'm glad you brought that up because there's nothing out there that's perfect. You know, the biopsy is the single way that we can say yes, no to cancer. And actually, I don't know if you saw, maybe I haven't reported it yet. On my UroNurse news, there's one of my episodes talks about a new phase where patients are going from abnormal MRI straight to radical prostatectomy.
Wow.
And their thought was what Fernando was asking about. Is there a chance of seeding? That was the thought process. Now, that's far from the accepted care route, but it is
Yeah.
something I reported. It was all a retrospective guys that, insisted I'm not going to have a biopsy but I would go for surgery. I don't know.
Wow. Wow.
As somebody who's seen, like I said, even in the best hands, there's complications. And if I'm the patient and I can minimize that by not having a procedure, I'm going to not have a procedure. Not meaning to not have a biopsy, but not have a, radical prostatectomy
Right.
without knowing I got definite cancer. So, well, anyway, I thought it's a good time to bring this up and, let people think a little bit about it, stew over what to do, and hopefully change. A million biopsies being performed, they said, still per year. This was recent data that we're still doing a lot of biopsies out there, and not everybody's gotten on that bandwagon, but hopefully that they will. And, it's interesting, the talk I had from the practitioner out in Glasgow, Scotland, they don't even do routine PSA on patients. The only reason you do a PSA is if somebody comes in with symptoms. So
Oh,
they're even trying to reduce unnecessary procedures even more. So got to
well, if they're
rethink these things.
symptomatic, you would think those are the people that are a little further advanced.
VPH type, or
Wow.
right, or further advanced. I don't know. I kind of said, you don't screen at like 50. Nope, we don't do routine screening. PSA not done. That was their
Wow.
answer. So I
Hmm.
said, they said there's got to be some issue that they're screening for. I mean, everything's, as we know, nothing's perfect. Maybe over screening isn't so great either. So
Right.
it's a change, and I think we have to be open to change. So,
Right.
all right. Well, great talk. Always have a pleasure to have you on the show, Lori. Now, next week, I hope you'll be joining us next week. I'm going to try to have a little bit of a panel discussion. There's a survey I've sent out. If you haven't done the survey, please do the survey. Well, let me tell you what it's
The best way to perform a voiding trial after catheter removal. Should you use the fill and pull method, allow the bladder to fill naturally, measure the post-void residual, or follow another approach? Survey says, there may be more than one way to do it. In this episode, I explore the important question of how healthcare professionals perform and evaluate a voiding trial. From bladder filling techniques to determining whether a patient has successfully passed the trial, this episode examines common approaches and the variation that exists in clinical practice. This episode is based on survey results from my viewers. I have invited some of the survey respondents to join me to discuss these results. Don't miss this episode on September 5th at 9 a.m. Central Time to learn more.
Yeah, I'm looking forward to that one. It's
Yeah,
always fun to
absolutely.
get people's opinions. I've been looking over the surveys coming in. Once again, if you haven't done the survey, I'm going to hold off crunching all the data until the very end. Go ahead, fill it out. It'll come out again with one of our newsletters, and it probably takes you 3 minutes to fill it out. But it's interesting to see what people are doing, how much it varies between different practices, how much it's the same. And this whole thing got sparked because I got a few questions from other healthcare workers out there who watch UroNurse. and said, hey, what should I be doing for a post-void residual? There was an argument, I guess, in their clinic. And I'm thinking, aha, there's an episode. So you guys are the ones who drive a lot of these episodes. And I love doing these surveys. It's a lot of fun. And in the old days, I had to kind of crunch the numbers myself, but I'm going to try a new thing. You know, me and AI. So I've got AI looking at, it's a Google survey. Gemini, which is Google's AI engine, can look at your data and it'll crunch it all together. Now there's nobody's name involved in all this. The only names are, if you want to be on the show, be sure to give me your email and I will put you on the show. Google won't know what to do with that. But anyway, tune in next week for that. Lori, have a great weekend and rest of the week.
And congrats again on 3 million views. That's great.
3 million. Maybe next week we'll be up to 4. No, it's a long climb to get to the 3 million, but I'm anxious. I'm excited. Hey, everybody. We'll see everybody next.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.